we'll say thank you to Dr. Cura for the invitation, but we'll have to pass that along later. Had a great time visiting and getting to visit this beautiful country. My first time in South America has been wonderful. Going to talk about current therapies for the aortic valve. We'll focus primarily on TAVI. A traditional approach to aortic valve disease, tried and true, we call it the gold standard, open surgery, done with a full sternotomy and now more commonly a upper mini sternotomy for those patients that are obese and want to recover quicker from surgery. It's a very nice operation with excellent results, low risk of morbidity and mortality. The options for valves are many. There's tissue valves on the right. Many generations we're on now to the third, fourth, or more generations of tissue valves. And then on the left, mechanical valves for younger patients for long durability. And which valve for which patient? We often struggle on this question. And I think for younger patients, certainly healthy patients, our standard is still to offer a mechanical valve for those under 55. I think there's reasonable data to say there's a survival advantage for mechanical valve if you're a young, healthy patient, avoiding the need for a redo operation or even TAVI down the road. If you're between 55 and 70, I think it's a good discussion to have with that patient, the pros and cons of a tissue valve versus a mechanical valve. Just 2 weeks ago, I had a 63-year-old patient that elected to have a mechanical valve and not a tissue valve. It's not really the norm. Most would go with a tissue valve, but it does happen, and I think it's good to empower the patient to make that decision for themselves. And then if you're over 70, our standard is really to recommend a tissue valve. In more and more, especially in the US, now that TAVI is available for all patients, we're offering the percutaneous TAVI valves to many patients over the age 70 if they have the right anatomy. We've kind of come full circle where we think TAVI first for older patients and look for a reason why surgery might be better, as opposed to before we used to think surgery first and then why TAVI might be better. But we've kind of flipped the coin on that in the US, and this is in the last few months as low-risk TAVI has been approved. So all patients, regardless of risk, are available for a TAVI valve. But speaking of TAVI, it's obviously the latest innovation in heart surgery, and there are many options, and they are growing. I think there's a pointer on here. Starting with the SAPIEN and core valve, the two common valves in the US. The Lotus valve on the edge is in clinical trial, and many others are in the design pathway in all different continents. The issues with TAVI, as it's really a new frontier, I think, as we will begin to answer in the coming years. One are the feasibility in low-risk patients. And I think some randomized trials are really needed, and those have come out now to say it is a safe procedure, very low risk of stroke and mortality. The durability remains the big question. Which device do we use? Is it a SAPIEN? Is it a core valve? Will it be a newer valve? I think we're going to have to wait until more data comes out in the coming years. Bicuspid anatomy and aortic insufficiency. These are very tricky. Most of the clinical trials excluded bicuspid valve patients, so we don't have a very rigorous idea of what TAVI valves look like in bicuspid valve patients. Specific valves are designed for this, the Lotus valve being one of them, to tackle these issues of bicuspid valves and aortic insufficiency. Valve thrombosis, we've come to know, is more and more of an issue. Certainly early on, some valves degenerate within 8 to 12 months. Why is that? Do we need Coumadin on some patients? Is there something about the anatomy that drives this? And a lot of the trials are including high-resolution CT scans in the post-procedural period to evaluate this question. Does this valve thrombosis occur At 30 days, at 6 months, it's something we're going to learn in the coming years about this technology. Durability, of course, the main issue. Same thing with the CT scans and echoes, looking at the valve and structural valve degeneration. How long does it last? And certainly as we start using these TAVI valves in younger patients, how long do these valves last is really a truly unknown question. I couldn't give you in a healthy 65-year-old, how long does a TAVI valve last? I don't have a good answer. 5 years? Maybe. More than that, I don't know. Avoidance of annular rupture, a rare but lethal complication, really less than 1%. When it does happen, though, it really is a crisis. Those patients often do not survive. And understanding about the amount of calcium in the annulus that puts patients at risk for this complication is something we're learning as we grow in our experience with this technology. Vascular access complications. In the early days, with very large catheters, 22, 24 French sheaths, we had vascular injuries, often having to repair iliac and common femoral arteries. That's reducing in its occurrence, mostly because the sheath sizes have gotten much smaller, 14, 16 French, and we continue to improve there. And the reducing stroke rate is another big question that we're trying to answer, and how to do that. And cerebral protection devices are coming in many different forms. There's one currently approved in the US. I'll talk a little about that, but that's something else we're going to figure out, how to really reduce the stroke rate as much as possible. It's amazing how low the stroke rate is with TAVI valves, despite there being no control of calcium when these valves are deployed. It's quite remarkable. So these are many of the clinical trials. Some have wrapped up, some are still ongoing, trying to address many of these issues. Partner 3 data really has come through. Early TAVRs enrolling, addressing the stroke issue here, Protect TAVI, looking at embolic protection devices. So we have trials trying to answer many of these questions for this new technology. One of the more current trials is the Lotus valve, and it specifically is looking at this intermediate risk in bicuspid valve patients, one of the only trials in the US specifically looking at this bicuspid valve registry, which will be very helpful. And speaking of bicuspid valves, it is very common, 2% of the population. If you're under 70 years old, you typically have a bicuspid valve. So as we move the TAVI technology into younger patients, dealing with this question of how these valves behave with a bicuspid valve anatomy is very important, because many of the registries that look at the outcomes in these patients aren't as good as in traditional trileaflet valves. And as you can see, there are higher paravalvular leak rates, 10% is high. Annulus rupture appears to be higher with the balloon expandable valves. A higher stroke rate, 2.4% with bicuspid valves compared to 1.6% with trileaflet valves. And a slightly higher conversion to open surgery. So the risks are higher. We are gaining experience, but it does remain a question because most clinical trials have not specifically addressed this issue. And just looking at what the valve morphology looks like between bicuspid and trileaflet valves. Seeing the raphe here, this very calcified raphe, we think that's part of the issue with the paravalvular leak rate and outcomes. And this just looks at the data specifically for the type of raphe. Some bicuspid valves have no raphe, some have a highly calcified raphe, and you can see the results in these with paravalvular leak and with annulus rupture with the calcified raphe is much higher. So we have to really pay attention to it. The Lotus valve addresses a lot of these issues. It's a mechanically expanded valve. It has a lot of external force, and it really does reduce the risk of paravalvular leak with these patients. The issue thus far has been the very high pacemaker rate because of that external pressure, as high as 35% in some studies. So some experience to learn how to really use this valve and whether it is the best choice for some patients, but it does specifically address this issue. But 35% is very high. And why does that happen? Anatomy review, the conduction system coming underneath the aortic valve, right by the membranous septum. The TAVI valves have to anchor right in that location. And the deeper and more in the left ventricular outflow tract these valves land, the more likely it is to compress this conduction system and cause heart block. There are some known risk factors: older patients, lower ejection fraction. If you have a conduction delay, a left bundle or a right bundle before your TAVI, you are more likely. But there are also some procedural things we can do: the type of valve we use, how deep we place the valve in the LVOT, and if we balloon the valve before the pre-dilation, when the balloon does seem to increase that risk of heart block by just a little bit. So those are the things we can control when looking at the reduction of pacemaker, because that, to me, is one of the biggest differences in most studies at TAVI valves with great outcomes, where the pacemaker rate is almost always higher than surgical valves, but we're working to reduce that pacemaker rate in the TAVI valves. And why does that matter? Well, if you get a pacemaker, you don't do as well as if you did not have a pacemaker. So we do want to reduce that complication after valve implantation, because patients just don't seem to do as well if you get a pacemaker. And how do we do that? Here's some real-time examples. Let's see, I might get this video to play. Might need help to click on that. I've broken it. Can someone in the back click on the left? Any help from tech support? I did see it play earlier. I know it can work. Do you have mouse access to click on it back there? Try to put a lot of videos so I don't have to talk as much. Yeah, advancing this. Is there a way to get the mouse live to click on it? No? Not so much. It's not working? Okay. We can't get can't get the pointer active, huh? Okay. That's too bad. Well, what I was gonna show, I'll try. I do have my computer. I can trying to go back just to show the last slide. Yeah, if the mouse won't go live, the pointer won't go live, that's how you would click on it. But if that's not live, that's okay. So doesn't line up quite right at this part of the video. But when you aim for where this valve will land, a lot of times the valve portion will land below the annulus, and this yellow represents the TAVI valve, the sapien valve, below the annulus, which gives a good seal, reduces paravalvular leak. But when you come this much below the annulus, you can often increase the risk of heart block and needing a pacemaker. On this side, after the valve is deployed, it really lands right at the annulus. We call that a 100-0, 100% at or above the annulus and 0% below the annulus. Here is more of a 80-20, which was the original typically taught positioning of a TAVI valve, 80% above the annulus and 20% below. But we've learned that does increase the risk of heart block. And if you can land it closer to 95% above and 5% below, or 100-0, that reduces the pacemaker rate. The core valve is a bit trickier sometimes. The pacemaker rate tends to be a bit higher. And part of the reason it's a little bit harder to control exactly where the valve is deployed, it tends to want to sit where it wants to sit within the valve annulus in the anatomy. You have less microcontrol. And in this case, the valve ended up, during deployment, dislodging and becoming supraannular. The core valve you can recapture, so we recaptured it. And if you've ever had to recapture a core valve because it went supraannular, you're much more aggressive to place it even lower, and in this case, had a significant amount of the valve below the annulus, which I think does contribute to a higher pacemaker rate with that positioning. And just a reminder that when you sit really low below the annulus, that valve sits well through the conduction system. If you can land it higher right on the annulus, it decreases the pressure on that where the bundle passes through, reducing the pacemaker rate. This will be a quick talk if none of my videos play, we'll see. Another issue with valves dislodging, I think that does increase the stroke risk. The stroke rate has varied anywhere from as low as 1.6% up to 6% in different trials. Many risk factors that we know about. If you've had a prior stroke, highly calcified anatomy, some things you can control. The things that you can control yourself are the procedure itself and potentially the use of embolic protection to reduce calcium going to the brain. So there's a slew of devices coming into market. This is one by Edwards, the umbrella deflector to place over the carotid arteries. The TriGuard protects all three, including the left subclavian. The vertebral artery is a rare artery to embolize down, but it theoretically can happen. The embol liner is a sort of mesh that coats the aorta and has a net that catches on the inside. You can see here, kind of like a fish net, will catch any calcium by letting blood flow to the coronary arteries. And then the Sentinel system is the one that is currently approved in the US. It protects the innominate artery and the left common carotid artery. And it can catch debris, clot, and calcium in those nets that you place before you do your TAVI. We'll see if this plays either. I'm guessing not. Still not working. It's a cool video. That's all right. It showed how the device went in. The data on using this Sentinel system does show a reduction in stroke up to 60%. What we don't know is which patients should use this device, and should it be 100% of patients? There are some complications with placing this device. You have to go with radial access, and you could potentially cause a stroke placing these nets into the carotid arteries. So it's not without risk. We just don't know yet which patients need it. Is it just the high-risk patients, or is it everyone? That's something we're trying to learn in this process. New technologies coming out in the TAVI space, treating aortic insufficiency. We don't really have a valve that does as well. Certainly nothing approved for pure aortic insufficiency, although it is a common problem both for aortic stenosis patients and for patients with just primary aortic insufficiency. The J valve is a new valve being developed. It can only be used in compassionate use within the U.S. With FDA approval, so it's very spotty in its use. But it has 3 rings around the outside that actually anchor into the leaflets themselves to help it seat into the outflow tract and annulus that doesn't require the calcium like a normal TAVI valve. It's a nice video showing this valve being deployed. Imagine how amazing it looks. Some challenges in the TAVI space to deal with. 2 things I will mention. One are small aortic roots with surgical valves already in place. The issue is more prominent with external wrap designs, the trifecta, freestyle valves, homographs, the old Soren MitraFlow. The posts sit inside the leaflets, and the leaflets sit outside the post. So when the TAVI valve is deployed inside, you have a risk of these leaflets occluding the coronary arteries, the left and right main, in a small root. It's less of a risk with a standard internal wrap design like the Magna valve, more common design, where the leaflets are on the inside, so those three posts act as a shield and prevent those leaflets from occluding the coronary arteries. So there are some ways we deal with that. I won't talk about it. The other are small bioprosthetic valves. If you have a 19 or 21 millimeter surgical valve, putting a valve inside those valves often results in a poor result with the persistent gradient. If you can imagine, if you start with a 21 millimeter valve, put another valve on the inside, your internal diameter is very small, and it's a very unsatisfying result. We tend to choose the core valve for those cases. It does have a lower profile and results in a better effective orifice area. And the other thing we have done is we have fracture valves. You take a high pressure balloon and can fracture many of the valves to increase your size one. So instead of putting in a 23 core valve, it could be a 26 core valve, which we would recommend for patients with very small prosthetic valves like a 21. One way we treat the issue of coronary occlusion with external wrap is something called the basilica procedure, where you actually take a wire and tear a hole in the tissue valve leaflet at the left main and sometimes the right coronary orifice before putting in your TAVI valve. This allows space between the leaflets to flow to the coronary artery after your TAVI has been performed, reducing the risk of coronary obstruction. Another video showing the basilica procedure. And this was sort of a real-time example of a case we did just a month or two ago of a double basilica. We actually tore the coronary leaflets of the left cusp and the right cusp before TAVI deployment. Those are the wires that we've passed through these cusps that we then actually electrify. We connect it to a bovie, turn the bovie on while we pull the wire up to shear the leaflet in two. In this case, it's the wire outlined by red there, hard to see, but it ends up getting pulled up. Video not gonna take, I don't think. Same thing, this is the wire tearing the right cusp, and then the final shot showing a root injection with good blood flow down both the right and left main coronaries. That's Nashville from 2011 is my hometown. This is where we're looking next year, so a lot of growth in the last 9 years. Thank you very much.